My name is Hiro Kawashima, the CEO of Prescience Health and your host of the Prescience Health audio blog series. We'll be inviting a variety of subject matter experts to weigh in on topics ranging from AI applications in healthcare to trends in nursing. Today, our guest is Scott Duncan, my coworker and the founder and CTO of Prescience Health. He has more than 25 years of experience in the healthcare field and served in leadership roles at the Sachs Group and SG2. He's a mathematician by background and has expertise in developing advanced resource forecasting algorithms. Welcome to the audio blog, Scott. So to begin with, I'd like to jump in right away and start off with a question that I often hear. What is the difference between forecasts and predictions?
Well, Hiro, a forecast is a mathematical process, usually a projection of the past into the future. For example, in an emergency department, if we assume that whatever has historically caused patients to visit the ED will continue for the next few days, then we might generate a forecast like there will be 80 visits to your ED during the day shift today. It's just a number. But a prediction adds additional context to make a forecast more useful. In our example, a good prediction might be it is 70% likely that there will be between 75 and 85 visits to your ED today, and so you will need 4 nurses. And if you only have 3 nurses on the schedule, then you should call in another nurse. An even better prediction might say that the severity of those patients coming in today will be higher than normal, so you should try to call in a senior nurse, or maybe even 2 more nurses.
Got it. So why do you think it's so difficult to forecast patient demand?
Well, like real estate, healthcare is extremely local. So no 2 hospitals are the same, and no 2 departments within a hospital are the same. The best forecasting approach for an ICU unit at an academic medical center is not going to be the same as for an ICU unit at a community hospital, and certainly not the same as the NICU or telemetry or women's services, other departments within that medical center. Adding to the difficulty is the influence on patient patterns of holidays, weather, pollen counts, school calendar, etc. And of course, a single event like a bus crash or a music festival or a winter storm can really throw off those numbers for several days. Any useful approach to forecasting patient volumes needs to be flexible and reactive and customizable to each individual department. In other words, it needs to be designed specifically for how healthcare works.
Got it, which makes sense. Obviously, a lot of companies today have developed forecasting algorithms for a variety of use cases. A lot of them are forecasting resource needs. So what are some of the methods that you use, as you mentioned, healthcare specific, to forecast patient demand?
At Prescience Health, we employ a forecasting approach called box Jenkins, which is best described as a model competition approach. For each department, we try out multiple forecasting models. Some are dynamic and some are more static, and then we judge each one on how well it would have predicted the recent history for that department. If the patterns for a department change drastically, maybe due to physician admitting changes or market competition changes, the box Jenkins approach will notice and switch to a new model that is more appropriate for the new patterns. We then layer on top of that base forecast several proprietary techniques that improve its usefulness for healthcare specifically. Then we combine the forecast with the staffing and scheduling guidelines for each department to generate the staffing levels by shift that will provide for that department the best balance between coverage and costs as defined by each department manager individually.
Yeah, that makes sense. And I think, as you mentioned, you're using a specific model that allows you to forecast some of these demand patterns. So besides looking at, let's say, things like patient census, which is what comes to mind for me, what are some of the other demand drivers that you can forecast?
Well, our staff right engine, it can forecast anything that directly impacts patient care requirements and has some historical data. So, for example, in the inpatient setting, we often will forecast not only census, but also acuity and ADT activities, admission, discharge, transfers. And this allows inpatient department managers to go beyond the traditional staffing grid to more accurately translate patient volumes into staffing levels needed. So, for example, in an ICU, your staffing guidelines may be set to say that patients of acuity level 4 need 30 minutes of nurse care each hour, but patients of acuity level 5 need 60 minutes of nurse care each hour, 1-to-1. And I'd also like to set aside an additional 20 minutes of nursing care for each ADT activity. Similarly, in an emergency department, we may be asked to forecast visits and census and severity, or for women's services, in the L&D department, we may need to forecast labor with and without complications, with cesareans, or we may need to look in the postpartum for different levels of recovery for the mothers, or in the nursery for different levels of newborn care, including normal, continuous, intermediate, and intensive care. So we built tremendous flexibility into our StaffRight engine on what demand drivers we can apply to determine each individual department's staffing and scheduling needs.
I see. And a lot of the questions today, especially when you're forecasting in these types of units, is around the accuracy of the forecasts. Obviously, if the accuracy is too low, the insights that are provided from these forecasts are limited. And then even the cost of accuracy can be a large factor in institutions deciding what system or what type of product to use. In this case, for StaffRight and for Prescience, what factors do you think influence the accuracy of the forecasts?
Oh, that is correct. Accuracy does vary quite a lot, not only between hospitals, but in between departments. In higher volume departments that have lower variability and a fairly steady length of stay, those are easier to forecast. So, for example, if your telemetry unit has 20 beds and is always full, then your forecast for next Tuesday is 20. But units that have lower volumes and higher variability, such as NICU or L&D, they are much, much harder to forecast and therefore much harder to staff efficiently. So, to help manage those more difficult departments, our forecasts are continually updated and improved throughout the day, and our StaffRight product has active alerting to notify managers and staff of any important changes to the staffing needs. StaffRight also provides tools to allow managers to see the staffing needs of forecasts across several units simultaneously. This helps managers balance staffing over multiple related units. And again, I have to emphasize that every department is different, and any product that claims to guarantee a certain level of forecasting accuracy is not being honest with you.
So that's a good piece of advice for anyone that's listening. Obviously, there's going to be a lot of products out there that do claim a certain level of accuracy across the board, but when you do look at the data, it often tends to vary based on unit and certainly based on the environment that you're operating in. So your specific hospital, your specific department, even your specific setup. So that's a good point of advice, Scott. I often hear a lot about machine learning AI, specifically in the healthcare field. That seems to be the buzzword of the day. But what are your thoughts on utilizing AI capabilities in this type of setting, and should it be incorporated into patient demand forecasting?
Well, the key word here is volume. Machine learning AI is not currently very helpful in forecasting how many patients you will have next Tuesday. But there is much promise that someday soon it will help with determining the staffing needs of the patients that are already in your hospital by predicting likely clinical pathways and procedures for individual patients, and then matching that up to the capabilities of staff to determine the best staffing to provide the best care given the current and near future case mix in each department. In other words, machine learning or AI can potentially supplement patient demand forecasting to further optimize the patient care your staff can provide to your patients.
That's also a good point to note. There's obviously some supplemental impact from using machine learning and AI capabilities, but it also does come with a cost. So every institution, every use case needs to think about whether AI and machine learning, like Scott, you said, can actually be promising or even have an impact, a sizable enough impact in this specific space. So thanks a lot for joining, Scott. Really appreciate it. Next week, we'll have Chris Luby on. He'll be talking more about what nurse managers go through on a day-to-day basis when they're looking at patient demand and forecasting. Thanks for joining.
Thank you, Hero.